Next we've got physical examination of nervous system. We begin by investigating the patient, and of course the first thing which we can tell if the patient is unconscious. So if he is unconscious and he is unconscious, you know that these are two first things what you virtually see first, and it can give you quite exact information about the general condition of this patient. So next, speech and language. Of course, you begin talking to him, and you can understand if he understands your speech, if he interprets words you are saying to him correctly. That means that his mental state is mostly clear. But there are conditions when you ask him question, you can see that he understands what you're asking, but he is answering slowly, or he can't speak aloud. He's like whispering, he's looking somewhere on the floor, and this also it can be a very valuable sign that he is in a condition which is close to critical or critical. So always pay attention to that. Always look where this patient is watching, how rapidly he replies to your questions, and what exactly he replies. Because, for example, if you talk about something that he doesn't want to talk about, this must be familiar to you and, of course, recognized by your clinical thinking. Next up, what you should know, it's cognitive functions. This is mostly about the course of psychiatry, the detailed investigation of cognitive functions. Classically, these include general questions about, for example, his name. You can ask him, what is your name? I'm pointing out that these are not regular questions you ask a patient within a surgical clinic. That's academic. For example, if you are not sure if the patient's conscience is clear, if he really understands what you are saying, and you want to investigate if he's mentally alright, such simple questions you may ask, for example, what is your name? What is your age? Where do you live? Where did you come from? Do you know where are you right now? Do you know who I am? What is the date today? What is the day of the week today? Who are your relatives? Who came with you together, or something like that. But these are questions you need to ask when something makes you think that his cognitive functions are compromised. If he is answering you the the answers which refer to questions you ask, if you think that his state of conscience is not compromised, you don't ask those questions. Next, we have a point of cranial nerves function. Well, we know that most of cranial nerves, they are responsible for innervation of head and neck organs. For example, number one, that's the olfactory nerve. This is the nerve which is responsible for smelling. You can check if he can recognize smells, if he has anosmia, dysosmia, or something, some other problem with interpreting smells. Next, other cranial nerves are relevant to eye movements. For example, nerve number 3, 4, these are oculomotor nerves. They are responsible for movements of muscles which rotate the eyeball. You can see if there is lesion in some of those. Nerve number 2, this is optic nerve. This is a nerve which is responsible for vision. This refers more to neurological status, which will be in more detail discussed in neurology course of your education. So other cranial nerves, you know, the trigeminal nerve refers for sensory innervation of oral, nasal mucosas. Other important cranial nerves you need to investigate are the acoustic nerve, which is responsible for hearing. Next, the accessory nerve, vagus nerve, and lingual nerves. You can see by the movements of his tongue if there is a deviation of a tongue. It might be caused by some injury of nerves that innervate the tongue, and so on. Once again, this is a more neurological point, so we won't stop on this in big detail in our course of general surgery. So, motor system. You can check if this patient can walk, how exactly was he delivered. Either he came by his feet, either he was delivered on a wheelchair, or he was delivered on a bed. He's lying and he can't walk. You must obviously take notice why exactly is he unable to walk. Maybe he has a stroke, maybe he has consequences of previous stroke, and he has a constant impair of locomotion on one side or two sides. Maybe he was a spinal trauma victim, or he had poliomyelitis, or he has the diffuse sclerosis. It's a systemic nervous disease. So all those locomotory functions, something which is not alright with his locomotion, it must raise questions about maybe he has some neurological disorder, a problem with either central or peripheric nervous system. But if you don't see that, you just write down that his locomotory functions are not damaged, and that's all. Next point, tendon reflexes. These are reflexes on the quadriceps femoris tendon, which can be studied on the ankle, knee, or it can be the reflex of Achilles tendon, which can be found on the posterior side of the ankle. These are also specific neurological symptoms, but just for your general knowledge, there is a very pathognomonic symptom which refers to a stroke with location in the pyramidal parts of cortex, and it means that the pyramidal neural pathways, which are responsible for innervation of extremities, are damaged. So you can read about the Babinski reflex. Babinski reflex is something you never see in a normal person, and if during your clinical investigation this reflex will be positive, that's going to give you some thinking if this patient has some uh, problem with central nervous system. So sensory examination, it includes examination of smell, vision, hearing, tactile senses, and locomotion. Uh, Once again, during writing a surgical case history, those points should be noted out in a very brief manner. Don't write it in a very big detail unless in a real life, in a real patient, you'll see some of those abnormalities which may be familiar to you. Their basal temperature can be low. It means that for a patient with hyperthyreosis, temperature level of, for example, 37 degrees Celsius, it's normal. He feels alright when he has this level of basal temperature, but a person with hypothyreosis may have a basal level of temperature like 36.0 or 35.78, no matter, and he feels also absolutely alright with this temperature. What you should notice is that if a patient without signs of thyroid hyperfunction or hypofunction has initially increased body temperature or lower body temperature, that's a crucial sign which you have to deal with. Another very important sign of hypothyreosis is bradycardia. And opposite to hyperthyreosis, hypotension. Also, patients with hypothyreosis have a very specific view of their face that's described in a specific manuals, literature, so we won't stop on that. What you have to keep in mind in those paragraphs is that you have to differentiate hypothyreosis and hyperthyreosis. Same goes for eye signs in thyroid disease. There are also amount of very specific eye symptoms like exophthalm, endophthalm, you will read about that by yourselves in specific manuals about thyroid disease, the endocrinology. Other findings which can be quite important when you are talking about the patient's endocrine status is visible signs of adrenal glands lesion. For example, if there is a specific tumor of adrenal cortex known as pheochromocytoma, these patients experience an extremely high levels of blood pressure once in a while. When I say extremely high, it means pressure with a systolic rate higher than 200, 220, 240 millimeters hydrargium. That's a very specific condition. Those patients, they know about it all the time, and for example, they can tell you that, you know, doctor, what's brought me here is this condition. Sometimes I feel those raises of blood pressure with this headache and increased temperature. I measure my blood pressure and it shows 220 millimeters hydrargium. I don't know where it comes from. So if you find out about that, or he tells you that, you must be aware that there might be some hormone producing tumor of his adrenal glands. Other signs which refer to pathology of adrenal glands are hypo or aldosteronism. Also, you may see signs of adrenal gland insufficiency. Very bright clinical condition related to pathology of adrenal glands is called the Addison's disease. Once again, we won't stop on those signs in very big detail. You may check it out in specific literature about endocrinology. But during your primary examination of any patient, you should always be aware that he might have a specific dysfunction of endocrine organs. And additionally to all of these, we know that there is another endocrine organ very important. I'm talking, of course, about endocrine part of the pancreas. Your primary patient may have diabetes mellitus. This is a very specific disease. You should always check if your patient has it, or if he doesn't have it, or he doesn't know that he has it. You should always clear this out in each and every patient. Why? Because, for example, if your patient which you are going to operate, he will appear to be insulin dependent, and he won't tell you that, and you won't gather this information during taking anamnesis. You may lose this patient. He might die because of hypoglycemia. Or, for example, if you are dealing with a patient who has underdiagnosed diabetes mellitus, you may find out that his initial level of blood sugar is extremely high, and if you won't take necessary actions, he also might die from hyperglycemia and hyperglycemic coma. So diabetes mellitus, it has not so many specific clinical signs, but be aware of diabetes mellitus, especially type 2. When you see an aged person who has a specific combination of excessive weight and essential hypertension. Together with increased level of serous blood sugar. So these three signs, if you find them in one patient, they are called metabolic syndrome. You must be aware that a very great part, the majority of patients who have signs of metabolic syndrome, they have type 2 diabetes mellitus. So in those cases you will obviously have to check their urine sugar. You'll have to perform extended diagnostic procedures for evaluation of grade of diabetes. You'll have to think of insulin therapy. Before and after surgery. So, quick overview. When we're talking about evaluation of endocrine system, you might see symptoms related to hypophysis dysfunction. Next, you may see signs of thyroid pathology, either hyperthyreosis or hypothyreosis. They may have specific eye signs, which you can also see very clearly in each and every patient. Don't forget about lesions of adrenal glands, and you should check all of your patients for their diabetes mellitus status. We remember that young people or children with increased levels of blood sugar, they usually tend to have type 1 diabetes mellitus, and if we see an aged person with excessive weight, essential hypertension, increased level of blood sugar, we know that these people have metabolic syndrome, and a very large part of them has underdiagnosed type 2 diabetes mellitus. Why should we be aware of diabetes mellitus? Because during our further treatments we'll have to correlate their insulin therapy. We must check their urine sugar to avoid damage to kidneys as a consequence of diabetes, and we have to involve either endocrinologists or other specialists who deal with this disease. But once again, endocrinology, diabetology, that's a very wide field of knowledge, and in your academic case history concerning general surgery, you should write all this in very brief details. For example, the patient shows no clinical signs of thyroid pathology, no clinical signs of adrenal gland pathology, he doesn't have signs of metabolic syndrome, and due to the normal level of his blood sugar, he doesn't have diabetes mellitus. That's all. Now we proceed to the end, the final part of our two parts of case history, which is preliminary diagnosis.